the basics of tumors, and there are few tumors that will be asked in your exam. One is a giant cell tumor, GCT, another is a simple bone cyst, another is aneurysmal bone cyst. These are the benign tumors usually asked. Now because it is going more into an MCQ format, you can be asked about the rare tumors also. They are not rares, but usually they were not asked previously in MBBS curriculum, like Osteoid Osteoma, Chondroblastoma, and Chondromas. So these benign tumors also you have to read about that. Now among the malignant tumor, you can, most of the malignant tumors like Osteosarcoma, you can also have a long question for that. Previously it used to come as a long question, but now it will mostly be in form of a short MCQ format. So you have to know about osteosarcoma, you have to know about multiple myeloma. So these are two important components. So let's see, we'll start with the. So bone tumor is a neoplastic growth of a tissue in a bone. So what is a tumor? So what we have read in pathology is, it is an abnormal proliferation of the cells. So it can be of, so abnormal growth which is found in the bone, which can be either benign or malignant. Okay. So it can be classified into two types. So they are called the primary bone tumors, so which has originated from the bone itself, and the secondary bone tumors. So secondary bone tumors are usually the METs. So you have a carcinoma breast, you have a carcinoma prostate. So from there you have metastatic deposits over the bone. Okay. So primary bone tumors can be classified further into benign tumors and malignant tumors. So benign tumors, exostosis. So exostosis is also known as osteochondroma. So we will come to the picture. What is exostosis? What is osteoid osteoma? What is osteochondroma? What is chondroma? What is fibroma? What are aneurysmal bone cysts? Will all come gradually. So all of them are different pathologically. All of them are different radiologically, and each of them have a characteristic clinical features and presentation features. So we need to see at that. Now malignant tumors which are important for you are osteosarcoma. That is very important because it will come as a short note. You have Ewing sarcoma. Now giant cell tumor is not malignant because this PPT was long back prepared by me. So it is now, according to WHO classification, it is something called in between. It is neither benign, it is neither malignant. It was initially thought benign, then because old neglected GCT started to show secondaries in the lungs, it then was classified as malignant. Then WHO classified it, no, it is locally aggressive lesion. It is somewhere in between. It is neither benign, it is neither malignant. So it has a chance for showing metastasis, but it cannot be classified as a malignant. So purely malignant are osteosarcoma, Ewing sarcoma. So these two are very important topics for your level. Now there are other types, synovial sarcoma, fibrosarcoma, chondrosarcoma, not needed for your level. But it is important to know that, okay, osteosarcoma is there. Osteosarcoma is an important topic for you all, and Ewing sarcoma. Okay. So what are the secondary bone tumors? So we need to understand that the secondary bone tumors, it has two kind of lesion. One is Blastic, another is Lytic. So most of the times, I don't know whether you go to the clinic. There was one very interesting case admitted in the ICU 1 week back. So the patient was a middle-aged lady, 50-55 years old lady, and she was suffering from carcinoma cervix. She didn't get operated, or maybe a late stage case, and we got an orthopedic refer for pain in the thigh. So when you look at the x-rays, it showed a fracture that was operated 1.5 years with a nail, but that didn't get united. But classically there was a lytic lesion. Then again over the hand there was a huge swelling. Now it was very, very rare to see a carcinoma cervix patient coming with METs in two sides. It was METs to the bone at two sides. It was one in the proximal femur, another was in the elbow. So the entire elbow was swollen, the proximal radius, proximal ulna was totally gone, full lytic lesion. So those are the classic things where you find lytic lesions. Now there will be certain cancers which undergoes metastasis, and when they throw secondaries, they will have increased bone, and that is called what is called a blastic lesion. So majorly all of these cancers will have a lytic lesion, but certain cancers, especially the prostate cancers, so they show a blastic lesions. So they show increased bone growth. But majorly all of the cancers like breast, thyroid, everyone, you are going to see a lytic lesion. Okay. So it is not mentioned over here, but you need to know that there is something called lytic lesion, there is something called blastic lesion. So majorly all of the cancers which you see when they show secondaries, they have a lytic lesions. Okay, it was a very good case actually. I don't know whether it's still admitted. It was admitted under medicine, I think. You are having medicine classes? Having. Okay. So now it is important to know. Now in the first class, you would have read about the parts of a bone: epiphysis, diaphysis, metaphysis. Now a patient comes with a pain in the limb or pain in the hand. You see a swelling, you see a long-standing pain that is increasing in nature, aggravated by movements, and is increasing in the night. It is not relieved by painkillers. So that gives you a suspicion, okay, that there might be something in the bone. You take an X-ray and you see a growth. But there are so many kinds of tumors. So how will you keep your diagnosis limited to that particular tumors? So here is where this type of classification comes. So you will know that, okay, this lesion is particularly seen in this epiphyseal zone. Okay, so this can be diaphysis. I am seeing a certain lesion in the diaphysis. Okay, so it can be this tumors, because these tumors are seen in the diaphysis. Okay, I am seeing some growth in the metaphysis which is not breaching the growth plate, but it is showing a lytic lesion, which is showing an expansile lytic lesion only restricted to the metaphysis. So there is some tumors that are found only in the metaphysis. So that kind of thinking will help you pin it down to a differential diagnosis. Now the interesting part about tumor diagnosis is you can only make a differential from a radioclinical diagnosis. You cannot pinpoint, okay, this is a GCT just by seeing an X-ray, because that has only to be confirmed by a pathologist. So when he is doing a biopsy, only then when you are seeing the tissue under the microscope, you can only say, okay, I am seeing this kind of tumors. So that is an important part of tumor diagnosis. So you have to pinpoint it to 2-3 things. You shouldn't miss a malignant or a metastatic lesion. You cannot label it as a benign. But if you are seeing some lesion, it is always better to do a histopathological diagnosis, because that will give you a ideal treatment plan. Okay. So epiphyseal lesion, chondroblastoma, giant cell tumors; metaphyseal lesion, again osteochondroma, osteosarcoma; diaphyseal lesions, Ewing sarcoma and osteoid osteoma. Okay. So these are some important things. So this is just a pictorial depiction of how you get it. So I think you guys would have read onion peel appearance. Yes. So where do you see it? Onion peel appearance. You see it's classical in Ewing sarcoma. So that is in diaphyseal region. See, Ewing sarcoma involves the shaft of the bones, 5 to 15 years of age, onion peel appearance on radiographs. So these are classical descriptions, and that will come in your exam if they are giving you tumors, bone tumors in orthopedics. So they are not going to give you something very difficult, but yes, these are something. Sunburst appearance, again you have to know where do you find sunburst appearance? You find it in osteosarcoma. Okay, so that are important. Codman strangle. So these are all periosteal reactions. So onion scale appearance, Codman strangle, sunburst appearance, these are all periosteal reactions. Periosteal reaction means there is increased growth, there is increased activity, and that all signifies that it is a malignant lesion. Malignant lesion has a tendency to proliferate more and more. So more the proliferation, more cancerous is the lesion. So more there is a potency for malignancy. Whereas if you see at the benign tumors, they will have a long history of presentation. So they will say that, okay, I am having pain for 3 to 4 years, on and off pain. Whenever I'm walking more, there is pain, there is some amount of swelling. And when you do an X-ray after 4 or 5 years, you will see, okay, there is something growing inside the bone. But the benign nature of this thing, so it will be a long history. The pain won't be that worse. The swelling would have been there for 2 to 3 months. So this signifies that it is a benign. So at your level, it is important to understand what is a benign, what is a malignant. So these are very difficult topics. There is a huge topic. This is actually not at your level, not an undergraduate topic, mostly a postgraduate topic. But what I want to give to you an out overview. So an overview of how to know what is benign, what is malignant, what are the presenting features of a benign tumor, what are the presenting features of a malignant tumor, and how to proceed with any tumor case whenever if you are seeing when you are going to pass your MBBS exam and when you are doing internship or you are joining for any house staffship. It is not good to miss any tumor lesions. So it is very important to know what you should do next. Okay, so yeah, so you can read from there also. Osteosarcoma typically affects the metaphyses 9 to 16 years of age. Now this age is very absurd. So there is no hard and fast rule that you are going to see at that age, but yeah, you can make a differential based upon what age you are seeing. So you can keep the age in mind, but what are more important are sun-ray appearance on the X-ray, and treatment we are going to come later. That is a separate part. So giant cell tumor, epiphysis, nowadays it is seen in the metaphyses also. So these are all overlapping lesions. So you can see in both. So now giant cell tumors have two presentations. You can see in 10 to 20 years, another age is 30 to 40 years. You can see both age of presentation. Soap bubble appearance, it will be classically that soap bubble appearance. I think we have an X-ray of a GCT, will show you, and treated with surgery. Treatment part you are going to come later. So osteoid osteoma, where did I say it's the most common region? It is in the diaphysis. So can you make it out from where? Now can you see this area, this thickening? This area? So there is increased bone. So osteoid osteoma is a osteoblastic lesion. So next will come the types of lesion according to the content of the tumor. So it can be a bone forming tumor, it can be a cartilage forming tumor, okay, or it can be a mixed tumor. So bone forming tumors, osteosarcoma, bone forming tumors, osteoid osteoma, bone forming tumors. Now it can have a cartilaginous tumor, chondrosarcoma, chondroma, these are all cartilage, okay. So the name will contain what type of tumor it is. So this is a bone forming tumor. So if you see, here is the thickening, and this kind of tumors usually present with pain in the nights. They will have a small nidus which can see only on the CT. You cannot appreciate that on an X-ray. If you do a CT and if you take the cuts appropriately, you will see there is a central hollow area, along with there is a thick blastic area. So that is where you find the nidus, and it causes pain because it releases prostaglandin E2. Again, what we have read in pharma, PGE2, that causes an increased inflammatory pain, and that results in the pain in the night. Classical pain in the night is formed by an osteoid osteoma, and it is a benign tumor. It is not going to go anywhere, it is going to stay over there, okay. So bone tumors can be classified according to the tissue of origin, the same what I was telling. So it can be METs. METs means secondary bone tumors. It has come from a different area. It is not origin from the bone. That is separate. Metastases, any METs. It can be from carcinoma prostate, carcinoma thyroid, breast, RCC, renal cell carcinoma, anything like that. Hematopoietic tumors. Most important topic of this is a multiple myeloma. At your level, you have to know multiple myeloma. It has origin from the hematopoietic cell lineage. What it does, you see what you call like the entire skull. If you see, it will be something called circumscriptor, cotton wool circumscriptor. So it should show cotton wool like Lytic lesions. I think we have an X-ray, I will show you. And there is an important criteria for that. It's called the CRAB criteria, CRAB. So C for calcium, R for renal, A for anemia, B for bone calcium. So all of this will be altered. So you need to read about that. So multiple myeloma is important, GCT is important, simple bone cyst, aneurysmal bone cyst, and from the malignant osteoid osteoma is also going to come because that's what reason I was telling you. And two of the malignant tumors, osteosarcoma and Ewing sarcoma. This 5-6 topics are important at your level. Now METs I am not going to go into detail because it can come from various. See, the most common bone METs, breast, prostate, lungs, renal, thyroid, these are most common. And thyroid or prostate, these two are going to show you blastic lesions. The rest are all going to show you lytic lesions, okay. Same topic. Let's go to the hematopoietic tumors. So these are hematopoietic tumors comes from the hematopoietic cell lineage. Okay. So these are important to know. Now there is this classification for multiple myeloma is based upon the IgG and IgM. So if this more than 30%, that is called a frank multiple myeloma. There is something called smoldering myeloma. I think you guys have read in pathology. Okay. And there is something called solitary plasmacytoma. So these are gradings. If it is a only single lesion, solitary plasmacytoma. If it is a transient lesion in between, it is a smoldering myeloma. And if it is a full-blown case where IgG is more than 30, the CRAB criteria is there. All the 4 features of CRAB criteria, there is hypercalcemia, it should be a renal injury, it should show anemia, and it have a bone calcium level is also reduced. That means the CRAB criteria is established, and then you have a full-blown case of a multiple myeloma. Okay. Lymphomas not needed for you guys. So yeah, this is the typical skull picture of a multiple myeloma. See, so the skull contains innumerable small lytic lesions, more or less uniform size, has been linked with an oil droplet appearance, metastasis. And see the nature of the skull. It looks like something has been taken out. Okay, so this is called the cotton wool appearance. If you see a cotton wool, it will be like that. So that is how it looks in the case of a multiple myeloma. See, can you see the multiple lytic lesions? So it will be like that. So from every bone there will be lytic lesions because the calcium content is reduced. The renal cells are damaged because you have something called amyloidosis. You have read in pathology, second year. So you have amyloid contents, and that is going to cause a altered metabolism of the bone, because for a good bone metabolism you need a good functioning kidney. If the kidney is not functioning, your bone metabolism is going to be affected, and that is going to cause a lytic lesion. See your lytic lesions in the proximal femur, you can see here the lytic lesions. You can see the pelvis, right? All small, can you see? These are all lytic lesion. This is again lytic lesion. So this is called the soap bubble appearance. So let's come to osteogenic tumors, osteoid osteoma. Today I'm going to give you a brief overview. We are going to come to all the topics later, but it is important to know that how wide spectrum of tumors we have. So we will have a class on detail on osteoid osteoma. We will have a class on multiple myeloma. We will cover that. But let's have an overview today. So osteoid osteoma is a benign bone forming lesion. It is small but very painful, and classically the pain is in the night. Okay. Symptoms occurs at night and are typically relieved by anti-inflammatories. Children, adolescents are affected. They can occur in any bone, more common in proximal femur. Diaphyseal location, give rise to a dense cortical reaction. Okay, this is important. These are all important salient features that I was telling in from the X-ray. Now see, this is the CT cut. So this I was telling. Can you see this area? Lytic lesion. And can you see this small dense bone? That is the nidus. And that forms the prostaglandins. And that are released typically in the night. And that is going to cause you the pain. Okay. See, it is written. Showing an osteoid osteoma nidus. Okay. And what is the treatment? See what they have done. Radiofrequency thermocoagulation. So what they do, because of intervention, radiology has become more advanced. We have particular lasers and thermocoag, the YAG laser. So what you do, you go and hit that area and you burn that sclerotic nidus, because that is the bone that is creating the issue. Now if you have that setup, you can do that. That is a minimally invasive. Now if you don't have that setup, if the patient comes to us, then you have to open the bone, we have to take that nidus out, and then you have to close it. So treatment we are going to discuss another day, that is not an issue. So what are the bone forming tumors? Osteoblastoma. Now what is osteoid osteoma and what is osteoblastoma? Now they are but osteoblastoma is relatively bigger in size. Morphologically and pathologically it is a little bit different from osteoid osteoma, but they are sisters. Osteoid osteoma is a small nidus, osteoblastoma is a bigger size nidus. That is the only difference that you need to know. So it is larger than osteoid osteoma. It is more aggressive. It is a counterpart of osteoid osteoma. Commonly occurs in the spine. Dull pain, not relieved by aspirin. This is important point. that pain was relieved by aspirin, because there the pathology was release of prostaglandin E2. And if you give NSAIDs, if you remember the pharmacology, how it inhibits the pain, well, it inhibits the arachidonic acid synthesis pathway. So it inhibits the prostaglandin E2, I2. So all that is going to relieve you the pain in osteoid osteoma. But this pain is not going to get relieved by aspirin. Okay, so that is a very important point. Now, if you see, this is an axial cut of a CT of a spine. Okay, so this is the vertebral body. These are the lamina. So sorry, these are the pedicles. These are the articular facets, superior articular facets, inferior, and these are the lamina, posterior part. Now, if you see this area, can you see a big blastic lesion here? So that is the osteoid osteoma. Now, the classical feature of osteoid osteoma, it is more common in the spine. Where, the osteoblastoma. And the osteoid osteoma is more common in the peripheral bones, femur, tibia. That is the difference. So now the malignant tumor, which is a bone-forming tumor. So we have come to an osteosarcoma. So osteosarcoma, we have the primary osteosarcoma and the secondary osteosarcoma. Primary osteosarcoma, it arises in the apparent absence of an underlying bone disease predisposing influences, where it is showing in cases where there is a genetic predisposition in patients with a P53 mutation, in patients with retinoblastoma. So these are the two important cases. Okay, so that are the primary. And from why it is secondary? Secondary means there is a predisposing lesion. Suppose there is an osteoblastoma which you have not been treated, and that has gone into an osteosarcoma. Now there are cases also of a chronic osteomyelitis. If you remember the class I have taken for chronic osteomyelitis, there I have mentioned one complication. It can turn into an osteosarcoma. So that is what we mean by secondary osteosarcoma. Primary osteosarcoma means there was no previous lesion in the bone. Because of genetic predisposition, there is a tumor. That is a primary osteosarcoma. Secondary osteosarcoma means there is a predisposing bone lesion or a predisposing bone tumor, which over the time, because you have not treated it promptly, it has now turned into a malignant lesion. Means a benign lesion has turned into a malignant lesion. So that what is meant by a secondary osteosarcoma. Okay. So primary osteosarcoma, it is because of genetic predisposing influences, most commonly occurs in second decade of life, most common in distal femur, then proximal tibia. Okay. Secondary osteosarcoma, see, it occurs on the background of some predisposing influences. So there is some disorder, there is some bone tumors that are pre-cancerous lesions, that are more prone to go into a malignant lesion. So those are the predisposing. Now where do you see Paget's disease? When there is a previous irradiation of the bone, fibrous dysplasia. So the Paget's is also a metabolic bone disease. So we will come to that later. Fibrous dysplasia is a bone tumor. So where you have a shepherd crook deformity of the femur. So if you remember, there was a condition where there is bowing of the legs, bowing of the femur. So that is a fibrous dysplasia. So again, we will come to that later, because these are all very difficult topics. Now, because it is a cancerous lesion, it has a predisposition to spread. And how does it spread? It spread via bloodstream to the lungs. Okay, so Mets to the lungs. Now see the osteosarcoma. You have different types of osteosarcoma. This is a broad classification. Now we have various types of osteosarcoma, but because it is predominantly a bone forming lesion, you are going to see a sclerotic thing on the X-ray. Okay, it is not going to show a lytic. Sclerotic means you are going to see a dense white thing on the X-ray. See, can you see here? And see the location. This is the growth plate. This is the epiphysis, and this is the, what is this region? Huh? Metaphysis. So from the metaphysis it is coming. Now we come to chondrogenic tumors. So the tumors which produce chondroid matrix. So it can be ranging from any, like bone forming. It can be from benign to malignant. So let's come to the benign tumors from the cartilage forming lesions. So osteochondromas. What is an osteochondroma? It is very common. Many of you might have also. If you palpate your knee, something might be protruding out. Many people have it, and that is a benign lesion. So it looks classically like a small tree that is growing from the metaphysis away from the physis. It is not going to go into the joint. It is going to go away from the joint and with a small cap. Okay. So this is a benign lesion, but again it is has a predisposition to grow into a malignant lesion. Okay. So what are the highlights of this? It is a benign cartilage capped bony projection, originate from the physis. Bone projection is always growing away from the joint towards the diaphyseal region of the bone. They can be pedunculated or sessile. So there are two varieties actually. One can have a stalk and then form a tree, or it can be directly just on the bone and form a mushroom cap. So which is going away from the bone, that is a pedunculated, and if it is going just over, it is called a sessile lesion. Okay. The stalk or the base is always continuous, usually solitary, but can be multiple. Okay. Let's see if we have an X-ray. Yes. Can you see this thing? So this is the pedunculated lesion, and then the tip, you are not see the tip. Can you see the tip? This is the cartilage, and cartilage will not show on the bone, but if you clearly follow the soft tissue shadow, see the soft tissue shadow. If you do an MRI, you will be able to do it. But the problem with this lesion is if the cap is more than 15 millimeter in size, and if it is growing continuously, that means it is tending to go into a malignant lesion, and then it can turn into an chondrosarcoma. So these are all precancerous lesions. But if it is solitary, over the years you have X-rayed the patient for 6 months at 1 month or 1 year interval, it is not growing in size, you can leave it as that. There are many patients who still come to us, and sometimes they tell pain, and they can be 40-50 years of age, and then you find out that okay, then it is an osteochondroma that was there during the childhood, that hasn't grown, but because he has done some extra activity, that is causing pain now. So those are the issues that we are facing. Chondroma. So chondroma are classically the tumors of the hand. So it will be the small bone tumors. There will be small lytic lesion inside the bone, in the phalanges especially. So these are the classical features of chondroma. See what is there. It is a benign cartilaginous tumor. 50% are in the hands and the feet. So that is a classical. Whenever in the exam you find an X-ray of a hand given, in majority of the cases it will be an chondroma. Okay. So they can present with pain, swelling, pathological fractures, often symptomless. Diagnosis is often incidental, associated with Olier's and Maffucci's. No need to know about this. These are again a broader term. You will come to know if you are specializing in orthopedics later, but not at your level. It's not needed to know. And usually diagnosed on MRI scanner. This is an important point. All the tumors you need to do an X-ray, and then you need to do an higher imaging in the form of an MRI. Now, it is not that I am saying all tumors need MRI, because you can see on the MRI only the cartilaginous tumors. But suppose if it is a bony tumor, then it is better to do a CT. And if you remember in osteoblastoma and osteoid osteoma, I showed you CT cuts. But here they are saying MRI. These are two different, because it is a cartilaginous tumors. Cartilage will show better on an MRI. But if you use a CT, I mean if it is a bony tumor, then your CT will show better. Osteoid osteoma can be picked up only on CT. In an osteoid osteoma, if you ask for an MRI, you will miss it. You are not going to find that nidus. That nidus will show only in a CT. So you first of all, it is important to know what kind of tumor you are dealing with. That is why classification is important. Whether it is a bone forming tumor, whether it is a cartilage forming tumor. And that you will be able to find out from the X-rays. So you need to know how to read an X-ray. So you need to understand it is a blastic lesion or a lytic lesion. If the bone forming component is more, you need to ask a CT. And then if you are suspecting, okay, there can be a cartilaginous component, then you can always go for an MRI. But if a bone forming lesion, if you miss it and then ask for an MRI, you can miss small lesions like osteoid osteoma. So that is not going to come up. Okay. So see, this is how an chondroma looks like. Can you see this part? Lytic lesion in the proximal phalanx of the hand. This is a hand X-ray. See? And see how thin the cortex have become. And then it can break. And if it breaks like that, it is called what kind of fracture? It is a pathological fracture. A fracture that is not caused by trauma, but due to some underlying disorder in the bone is called a pathological fracture. It can be due to a metabolic disease, it can be due to a tumor, it can be due to many reasons. But if it is a fracture without a trauma, then it is a pathological fracture. Okay. We're going to leave this part. Olier's Maffucci is not needed for you guys. Chondroblastoma. So this is another cartilage forming bone tumor. Little bit different than an Chondroma and from a chondroblastoma. So, is a benign cartilage forming tumors occurs in the epiphysis of the children and is most common around the knee. Classically, this question used to come with the pathological finding as chicken wire calcification. I don't know if you remember in pathology, if you guys have read, this will come as chicken wire calcification. If you see the pathological picture, so this has a Chinese letter kind of thing, and that will characteristically show up on the pathological slide. So these are the tumors that are going to be asked in your exam with this kind of words: sunburst appearance, onion peel appearance, chicken wire calcification on a pathology slide, on a histobiopsy slide. So these important terms you need to understand. Anyway, you are having to have a class on detail on this, then I will speak about it. So chondroblastoma, if you see the lateral X-ray, you cannot make it. Now, if you are doing a sagittal CT reconstruction, can you see the emptiness? It shows that the bone is not there. So there is something inside. Now, if you have seen, I don't know if you have the MRI, I don't think you have the MRI, no. So if you do an MRI at this level, then you can see the fibrous tissue, the cartilaginous tissue that is filling inside. All these are benign lesions. They are not going to cause you any harm. This is going to stay only if it goes a pathological fracture. Only the risk is, see, if it grows in size, what will happen? Now the patient, this is the knee joint line. If the patient starts to walk, excess pressure, it can break. And then that is going to cause pain and all. Otherwise, chondroblastoma is a very benign tumor. It is not going to cause anything. Okay. Chondrosarcoma not needed for you guys. No need. So it is just a malignant transformation of all these lesions. So whenever a cartilage forming tumors from the benign, if it goes into malignant, it forms a chondrosarcoma. Just remember this. That's all is enough. Now, what are the other types of cysts? I mean, the other types of tumors that you need to know. So one is a unicameral bone cyst, which is also known as a simple bone cyst. Then you have the aneurysmal bone cyst. Aneurysmal bone cyst is very important. So when you have multiple loculated lesions, simple bone cyst will be a cavity with a fluid-filled cavity with a single, sometimes called the fallen leaf fragment. The classical X-ray description is a fallen leaf fragment. Aneurysmal bone cysts and GCT are very close to each other, so they are almost similar. But if you see under the pathology slide, it will be different because the components are different. Okay, so this is a spindle cell tumor. Giant cell tumor is a spindle cell tumor. That are all pathological findings. But an ABC is a, what you say, I mean, it is a simple bone cyst that has aggravated over the time and it has formed multiple loculus. Let me see if we have an X-ray. And next important that you need to know is an Ewing Sarcoma and fibrous dysplasia. It is good to know, but not in detail. So at your levels, from 4-5 tumors are enough, not more than that. Now you need to know, because problem is now you have to do MCQs. Previously, there used to come, orthopedics used to come as a small part along with your general surgery theory part in the exam. 2 to 3 long questions and 10-15 short notes would have been enough. Now the problem is, because you have MCQs and now they can ask you anything. So they can in the theory, in the practical exam, they can just give you an X-ray with a small description and then they will ask you 2-3 questions. Not difficult, but at least you need to know the names. If you don't know the names and if you don't know how it looks, then you cannot answer it. That is the problem. See, this is how it looks. Can you see the big cavity? This is a proximal humerus, shoulder joint, okay? So this is the big cavity, and can you see this one long flake of bone? So how does it look? It looks like a leaf from a tree. I know it doesn't look like that, but you have to imagine it. It is a leaf. You have to agree with me that that is a leaf, because that is how we were taught. We are still reading and you guys also have to know. So the leaf is this one. It looks like it has fallen into a cavity. So that is why they have called it a fallen leaf sign. Okay. See, simple bone cyst with a pathognomic fallen leaf sign. So you cannot miss it. This is a classical simple bone cyst. And why has this patient come? This has not come because of pain. This patient has come because he has sustained a pathological fracture. See the fracture. Can you see the fracture? See the break in the cortex, break in the cortex. Because the cyst has started to grow, it has thinned the cortex of the humerus And just because of a simple trauma, or maybe he has just put his hand like that and it has broke. The patient has come because of that. The simple bone cysts are rarely going to cause pain in any patient. And these all will be pediatric patients. See, how will you know the pediatric patient? See, the physis is open. Can you see the physis? This is the head of the humerus, this is the greater tuberosity, and this is the physis, and this is the metaphysis. Classical metaphyseal location in a young bone, 8 to 15 years of age, with a pathological fracture, simple bone cyst. Again, a very important topic. So this kind of x-rays can come. These are very catchy. They will show you this x-ray. 10 years old boy has presented with pain. Identify the x-ray. Differentiate. They might ask you the diagnosis, but it is very harsh to ask you a diagnosis because no one can tell confirmedly that it is a simple bone cyst. Because that can be diagnosed only after you have an x-ray, you have an MRI, you have a CT, you do a biopsy, then only you can do. But they can ask you for a differential diagnosis. Differential means you have to name the close options or the brothers in this group. The brothers in this group are simple bone cyst, aneurysmal bone cyst. You cannot miss this two. You cannot write this as a Ewing sarcoma. That is crime. Okay. So you need to name what are the closely related things. Okay. So this is classically how a simple bone cyst present. Aneurysmal bone cyst. Now see, it is so similar, no? You cannot make any difference between a simple bone cyst and an aneurysmal. But what is important to know is that it is a lytic lesion, expansile, and it is, see how much cavity it has formed. And if you see closely, can you see the multiple loculas? Here one is cavity, one cavity, one cavity. It's not very clear, but the classical of an aneurysmal bone cyst, it is expansile. Simple bone cyst was not expanding in size, it is expanding in size. Okay. But again, it is a very similar and close lesion to a simple. They are sometimes synonymously used. Sometimes the radiologist will give, okay, that is aneurysmal bone cyst. Sometimes someone can say, no, it is a simple bone cyst. But they are very close. Okay. So it is a benign, benign cystic lesion, bone consisting of blood-filled spaces separated by fibrous septa. So this was what I was telling. So this will be small septa. So you cannot make it out in this, but if you do an MRI, you will see beautifully all these septas. Okay. It is much more aggressive than a simple bone cyst and often presents with pain and swelling. Let's see giant cell tumor. Okay. So what did we read? Epiphyseal location. Can you see the physis is totally involved? This is a distal radius, wrist X-ray. Now see only the joint line, you can see a thin bone and see the entire destruction. Can you see the lytic lesion? In the X-ray, it is totally black. That means it has eaten away all the bone. When it eats the bone, it is lytic lesion. When it grows bone, that means it will be very white on X-ray. That is a plastic lesion. So this is a lytic lesion, expansile. See why it is there? Because of the osteoclast-like giant cell. Here the osteoclastic activity is more and it forms giant cell tumors. It forms a foamy, large giant cells. Histopathologically, it is a spindle cell tumor. And that's why it has got its name, giant cell tumor. Okay. 20 to 45 years, physis, after the physis have closed, affects the epiphysis of the long bone, especially the knee, proximal humerus and distal radius. Very common. Very common to find these tumors. Giant cell tumors, very common. Simple bone cyst, aneurysmal bone cyst, osteoid osteoma, chondroblastoma, exostosis. Exostosis is actually the name of an osteochondroma. Whatever, osteochondroma and exostosis are same thing, just fancy names of both the same tumor of fancy names. Okay. Eosinophilic granuloma not needed for you. Fibrous dysplasia is a very bad X-ray of a fibrous dysplasia, but okay, we'll cover it. So this is a benign fibroosseous lesion, affects the long bones, pain, swelling, and see what I call shepherd crook deformity. So it will be forming like a cane. If you see the femur with the fibrous, most commonly it is seen in the femurs actually, and it forms a shepherd crook deformity. I'm just telling this because these are very catchy names. Fawn and leaf fragments, shepherd crook deformity, chicken wire calcification. This is how it is going to come in your exam. Because these are very catchy names. They are not going to ask you silver dollar sign or something very rare in eosinophilic granuloma. They are not going to. Undergraduate level, that is not needed. Undergraduate level, fawn and leaf fragment, yes, needed. Giant cell tumor, soap bubble appearance, needed. because that is how it is going to come. They will show you an X-ray and then they will try to describe it so that you catch it. But if you don't know, then you cannot answer. So you need to know it. So these are important things that you need to know. Ewing sarcoma, see, again it is highlighted, onion skin, onion peel. These are all periosteal reactions. See, it is written, periosteal reaction. So again, Ewing sarcoma, where do you find? Diaphysis of the bone, painful mass, fever, anemia, increased DSR, all you will see all aggravated because there is a malignant lesion. So everything will be high. Okay. Don't worry, we are going to have a detailed class on each of the topics. What I wanted to do today is to give you an overview so that you know how wide the spectrum is and how you should approach this. Okay. Diagnosis of bone tumors, what I have said, anyway, you need to take a history. That is important. How long it is there, how is the pain, when is the pain. So the pain history that you take in any surgery or a medicine class is the same, be different. That is going to be the same. Along with that, you need to do X-rays, CT, MRI, PET. If you are suspecting a malignant lesion, if you are suspecting a METS, then you have to do a PET. But X-ray, CT, MRI is a must. That has to be done. And only after you finish all this, then only you put the needle. That means biopsy comes last. That is the last thing that you should do. That is a very important thing in the investigations. You have to know the principles of management of bone tumors. All biopsy should come last. You should not do a biopsy before not doing MRI. Your MRI, all your imaging should be complete. Then only you should put the needle. Okay. Otherwise, you are going to spread the tumor.